So let me introduce Dr. Noah is interventional neuroradiology from UCLA, and she has so kindly going to talk to us about advances in digital health and artificial intelligence for acute stroke recognition and triage. Thank you, Dr. Noah. How's your slides?
Thank you. Now I think we're gonna. Can you see my slides projected right now?
Yes.
Great. Such a pleasure to be here with you today in Pomona Valley. Thanks for welcoming us. I'm presenting on behalf of myself and my colleague, Dr. Rachel, who was not able to join today as he's out of the country. So today we'll talk about advances in digital health and artificial intelligence for acute stroke recognition. And as you kindly presented, I'm one of the interventional neuroradiologists at UCLA Health. I also do stroke vascular neurology, and I head the mobile stroke rescue program for our county. So I'd like to give you a little bit of highlights of all of the things that are happening and the advances looking towards the future. And I'm happy to answer any questions at the end as well. These are my disclosures. The acute stroke workflow is complex, and synergy in this workflow is essential for establishing what we care for the patient is a great outcome. And it starts with the 911 call taker taking a call and dispatching a specific vehicle, whether that be a regular standard EMS 911 response or a specialized unit such as the mobile stroke unit. And this dispatch is crucial to identifying stroke signs and symptoms and triaging patients to the most appropriate level of care. Once we get to the hospital, you as a comprehensive stroke center know more than any that speed and efficiency and also very good effectiveness in managing the patient is essential. Getting to scanner fast, alerting teams who are integral in helping the patient, whether that be stroke neurologists, neurointerventionalists, neurocritical care, or neurosurgeons, getting the patient to where they need to be initiating treatment, and then not just initiating treatment, but caring for the patient afterwards to make sure that that treatment and these good outcomes are sustained through not only their critical care stay at the hospital, their floor stay, but also through neurorehabilitation. So it all starts with EMS stroke assessment. This is something very near and dear to my heart. And as we're in the field with mobile stroke unit, it is becoming more and more significant for us to understand that accuracy of dispatcher impression is very important because the right resource has to get to the right patient. And EMS stroke assessment, once the paramedics arrive on scene, has to also be very critical and very efficient. And there are many, many types of apps, and I'll share with you lots of new future apps and apps being used right now to help expedite and improve patient care. This is, for example, the RACE stroke scale. This is a mobile app by Get Ahead of Stroke. And of course, as we use LAMS in LA County, other counties use different stroke scales, which incorporate cortical signs that are important for detecting signs of large vessel occlusion. In terms of large vessel occlusion that's more effective in the field, other than scales, which are suggestive of what the patient may have, many companies have come up with devices that can be portable and mobile. What you really need in the field is something that can be fast and quick, you can do on scene, and it can be not only sensitive but specific to detecting large vessel occlusion. So Novo Signal is one of such devices that uses transcranial Doppler to detect large vessel occlusions. However, as you know, if you do TCDs in-house, many patients may have thickened bone windows, and that may prevent signal insonation. Another type of device that looks at rapid detection of brain injuries through Cerebrotech visor. It looks at volumetric impedance and phase shift spectroscopy. There are other devices that look at infrared spectroscopy, looking at oxygenation of the tissue. And of course, there are more definitive ways to do that by actually scanning the patient in the field, or basically having a primary stroke center on wheels. And that's the concept of the mobile stroke unit that was initiated as a public-public partnership between the University of Arizona, oh my gosh, no Oklahoma, no Arizona, University of California, and the LA County Board of Supervisors to transform patient care, bringing this technology. And there are two landmark trials showing the clinical benefit of MSUs in ischemic stroke. One as an international study out of Berlin, that's Be Proud, and one as a U.S. collaborative, Best MSU, where 7 U.S. cities participated, including the Los Angeles Mobile Stroke Unit. And both showed clinical benefit to patients who receive imaging in the field, initiation of therapy for IV thrombolytics in the field, relative to standard care when the same patients receive IV thrombolytic once they get to the hospital. And if you think about it, it's a time-based effect. And looking at the number needed to treat for benefit. So how do you explain this to someone in a simple way? So out of 100 patients treated earlier in mobile stroke unit with clot busting medications, rather than treat later with the same clot busting medications in the emergency department, 27 will have a less final disabled outcome, 11 of whom will be disability free. This is incredibly significant, and this is over the effect and benefit of IV thrombolytics. What about cost effectiveness? What does that mean? So the Best MSU trial published or presented the cost effectiveness at ISC, and the cost effectiveness is identified in this ICER term, which is incremental cost effectiveness ratio. And there is a specific ICER for each country, and based on calculations for ICER for the United States, something that's highly cost effective is less than $63,000, and the mobile stroke unit care for patients resulted in, for health care per quality adjusted life years, only 33,537. So showing that not only is this clinically beneficial, but then highly cost effective. In terms of our clinical operations, and you may have seen me present some of these slides previously, these are the capabilities of our mobile stroke unit in Los Angeles. We are staffed by a vascular neurologist, either in person or by telemedicine. In fact, 2 of us are also interventional neurologists. There's a firefighter paramedic. Currently, we have 2 fire department operating our rig, Long Beach Fire, as well as Torrance Fire. We have a critical care or emergency medicine trained nurse and a CT technologist. We're able to do Chem 8+ and CoaguCheck within the vehicle. We're able to image not only the tissue of the brain, the parenchyma of the brain, but also the blood vessels of the brain. So no longer do we have to rely on just the LAM score of 4 or 5 predicting LVO or suggestive of LVO, but we have concrete evidence with a CT angiogram whether or not there's a large vessel occlusion. With regards to perfusion, this is less useful on the rig, I'll say, because of the 8-slice scanner right now limits the capability of slicing only or post-processing only through one section of the brain, which is not very useful unless you have, an ICA occlusion that may show that. So for now, we're not doing CT perfusion on the rig. We hope as more advances in technology for CT scanners develop that we are able to do that. So in terms of ischemic stroke capabilities, we're able to treat with IV alteplase or IV tenecteplase, and we have been carrying tenecteplase since maybe now a year and a half ago. It's Dr. Saver with our first bottle or our first package of tenecteplase on the rig. And how we decide which medication to give is basically based on destination of the receiving hospital for the patient. I know the mobile stroke unit doesn't currently come to Pomona. We hope one day we can service Pomona area as well, but we, depending on the receiving hospital, we use what they use. We currently drop off patients to 15 different receiving centers within LA County. For hemorrhagic stroke, we carry Kcentra actively. We're planning to carry Indexa Alpha for hemorrhage reversers for NOACs. And of course, we have anti-epileptics, anti-hypertensives, ACLS medications, and so forth. These are some of our pictures from the field that you can see with the paramedics really interested in what's happening with the patient. And for the first time, not only can they get same day feedback, but they can get same moment feedback by seeing what the scan shows, watching the treatment for the patient, and able to participate in that patient's care kind of in a full circle way. We've only had to intubate 1 patient so far in the field since the essence of our operations in September of 2017. This is a patient who was found down, was dispatched as a seizure dispatch. When we came, found fulminant and subdural hemorrhages, and had emesis, and we needed to intubate him. So how do we transition from evidence-based to practice? We did a study looking at geospatial mapping for stroke occurrences in LA County. And in this study, we included patients who were dispatched by EMS 911 calls and had a final hospital diagnosis of stroke. So not dispatched only a stroke, dispatched as anything, because as we know, the dispatcher impression is currently quite inaccurate. And out of these patients, about 10,000 patients included. Now looking at the characteristics of these patients, in these 10,000 plus patients, this was the mean age. Female was about 51.3%, hemorrhagic and ischemic stroke, as you expect, the natural history of the proportions of these, and they had a quarter of them had a Lamb score above 4. And these are the percentages of ischemic and hemorrhagic stroke, and this shows who was in the time window and outside of the time window. And in graphing these, in LA County, what you're looking at is a map of LA County, and what you see as darker shades are areas with higher stroke incidence. And so if you look at the first graph on the left-hand side, these are numbers of stroke per month, and you can see that there are pockets with higher incidence in and around San Fernando Valley, San Gabriel Valley, Inglewood, and so forth. And this is reference to strokes per month per 100,000 residents. And these are the incidents by highest incidence by zip codes. These are graphing ischemic strokes versus hemorrhagic strokes and where they occur. So as you notice, there may be areas like Palos Verdes here who have a higher incidence of ischemic stroke, but really not lighting up as a high incidence in the hemorrhagic stroke. And that has to do with the population inhabiting those areas. And of the day and night, looking at both, no difference between Monday through Friday versus Saturday, Sunday, about 71% of the strokes occurring during the so-called daytime hours, 7 a.m. to 7 p.m., and about 29% in the evening time. And this is the distribution day versus night. And if we looked at individual stroke calls, so looking at this map, each tiny blue dot is a 911 call that resulted in a final hospital diagnosis of stroke. Each red dot is a stroke center, PST, TST, or CST in our county. So we asked the algorithm to choose a number of units that could be within a 10 to 12 mile radius that can overlap in our county to serve all of these communities, and this is how the algorithm chose. And then we asked it to force in 2 additional one because it didn't initially pick them because of not high incidence of stroke relative to the others, but these are geographically disparate areas. So we anticipate that perhaps 7 of these units could cover the entirety of LA County and be able to serve its citizens. And here are some numbers of the coverage. And with looking at one provider agencies, there are 28 different 911 EMS fire departments within our county, and LA County Fire has the one with greatest breadth, meaning that they're scattered more in different areas of the county. So we identified even fire stations where they could be positioned. This would be our dream one day, but as you know, also traffic patterns dictate that. Monday through Friday versus Saturday, Sunday, the traffic is quite different in Los Angeles County. So how do you account for the movement of these units and getting to the patients on time with the traffic pattern? So this was our geospatial mapping model, and we hope that one day again we can serve Pomona and the citizens surrounding it. So what about now EMS to hospital communications? Many other technologies have developed to do that. For example, Pulsera, this is one type of technology that not only time keeps, but acts as a communication tool between EMS to the hospital and inside of the hospital as well. Other apps include Triage, that's something very similar, and Triage, my understanding, is that also has a Zoom interface for telemedicine in some cases when the providers want to participate. Join is another such app, so you can see a big movement to really bring the next phase of care and technology to patients in EMS. Capture EMS, which I'll tell you about today, and you're using actually in Pomona as a trial, is one of our apps that I'll talk to you about. And what about standard EMS stroke triage and transport in LA County? These are the recommendations by American Stroke Associations for regional stroke destination plans in rural, suburban, and urban communities. And you can see how they have the algorithm for LVO patients. So if an LVO is suspected, if it's yes, and a CSC is within 30 minutes maximum transport time, transport to CSC is the right answer. If it's no, if you have to take more time to get to the patient, then transport to thrombectomy capable centers. And if not, then transfer to the nearest PSC. And if LVO is not suspected, then transfer it to the closest stroke center. And that's what's happening at this time in LA County. However, in LA County, I want to stress that there is no distinction between CSC and TSC. So they are lumped together. So paramedic from their end, they call them CSC level 1 and 2, but they do not differentiate in their transport between TSC and CSC. However, the mobile stroke unit can do that because based on conclusive imaging, we cannot transport a hemorrhage patient, for example, with a LAM score of 4 or 5 to a thrombectomy capable center. That patient should be directed to a comprehensive bypassing TSC. What about data sharing and feedback? It's, again, a complex system of care that allows us to care for our patients, and that starts with EMS, the emergency department, stroke team, radiology, neurology, and interventionalists, and how, of course, neurocritical care, neurorehab, and everybody, social work, physical therapy, occupational therapy, everybody that participates in the care of the patient, how do we all communicate efficiently and effectively? There are other imaging apps that are AI imaging apps who help us expedite care in different systems. For example, myself as an interventionalist, before I used to have to park the side of the road in the car, log onto a VPN, try to log onto a computer system, which is really declining precious minutes for the patient. But now, even on my watch, I can see right away, this is a go case. This is I can see the LVO, I can see the detection. In some of these cases, although the AI is not as precise as we'd like it to be, they act like a PACS in the pocket. But the AI is pretty good that even my children know when it's a go case or not. And they say, Mommy, oh my God, such a huge mismatch. And we go for the case. So the AI has helped us significantly, although Rapid is just one of these apps. There are other apps, for example, Viz AI, and others which your hospitals may use. Now brings us to the part of the talk that I'll talk about our technology with Fast AI and Capture EMS. And the question is, can AI detect stroke symptoms? We know that the problem is that over 800,000 strokes per year, and only 5% of these patients receive treatment within the golden window. One reason is that 27% may not know that they have a stroke. As you know, stroke can come with symptoms of neglect. Patient may be incapacitated, so 70% can't call because they're having stroke symptoms. And up to 70% of all stroke patients will achieve full recovery if treated within 3 hours, and you can see these type of diagrams looking at the numbers. So what you see in blue is the patients who can benefit the earlier you can be treated, and what you see in gray is the patients who no longer benefit after treatment. We live in a world, though, where solutions can be implemented to detect stroke in an ambient environment. So many stories in the news. We've seen a FaceTime woman chatting on FaceTime, and somebody recognizes that she's having a facial droop. A news anchor in Oklahoma, in fact, had her colleagues jump to action because her stroke symptoms were apparent on the air. A patient on a Zoom call was identified because of that. In fact, on the mobile stroke unit, I responded to a patient who was on a Zoom call with her therapist, started to have a facial droop, dysarthria. The therapist noticed that, alerted her, and those symptoms, subsided very fast. By the time she went to her husband, she was back to normal. It was in the time of COVID. She was not convinced to go to the hospital, and the paramedics allowed the mobile stroke unit to continue on scene. They told her a neurologist is there. Maybe you can talk to them and get some advice. And hearing her symptoms and understanding her risk factors, I pleaded with her to go to the hospital. And although her symptoms had fully resolved, MRI in the hospital showed bihemispheric multifocal stroke with rapidly resolving symptoms. Turns out she had a high-grade Spencer shunting PFO and was treated, and was very thankful and contacted me afterwards to say thanks. But at this time, what was detected was seen by somebody on Zoom. Nearly 1 in 3 young adults in the U.S. still doesn't know the common symptoms of stroke, and we use FAST or BFAST to look at that. And what the technology of Fast AI does, and I'll show you the research that we have on that, is it looks at facial asymmetry, speech disturbance, and arm weakness at this point. Further modules in the future will include looking at gaze preference, ataxia, language specifically for aphasia. So this is how it works. You have a test subject, and the data is acquired on a mobile device. There's a video that's recorded, so you can see a facial video. You can see the arm motion by a gyroscope, holding the phone in the hand, and a voice recording helps with slurred speech. So we can detect asymmetry, arm weakness, and slurred speech at this time, and the results are merged. We use the video recording and a proprietary ML model to capture and track these asymmetry. Our current model had 68 facial point landmarks and key points to model and do linear discriminative analysis of changes. However, now we have developed a technology with 90 points of landmarks on the face that include more sophisticated features, like including the nasolabial fold. Another really important thing this could be good for is identifying for the medics on scene a peripheral facial nerve versus a central response. So these are the annotation of the results, looking at the right side of the face versus the left side of the face. And the candle on the left-hand side represents the certainty and estimate, the probability of symptoms. And what you can see here is acceleration of the left arm and the right arm. And looking at the variance in acceleration tells us in the X, Y, and Z axis about which arm could be weak. In this case, the right arm is affected. And looking here at measuring angular velocity using gyroscope, again with the right arm affected, you see a clear difference in pattern between the gyroscopic footprint of the left arm versus the right arm. You can see more variance on the right. So with a steady lift, this is a healthy arm, so it will show you that. This is the normal reaction. With the steady lift, accelerometer, and the no drift steady arm. With the gyroscope, you can see the normal rotation of the arm and then a steadiness in the gyroscopic features. And this is with subtle weakness. You have a staggered lift. You have transient unsteadiness, but you still have on the gyroscope a normal rotation. Again, this is a subtle weakness in the arm. Looking at a moderate weakness in the arm, you can see the staggered lift increase, the drift increases, and the staggered rotation becomes apparent on the gyroscope, and so forth as it progresses. Longitudinal trajectory over time shows the lift, improvement in the lift, as well as the drift. And now how the speech module works. Using a voice recording to conduct analysis of sound variability and patterns, we can detect at this point slurred speech and speech abnormalities, but it's not detecting for language or aphasia at this point. This isn't a future module. You can see the MEL frequencies extracted with ridge regression run, so showing the pattern of normal speech and the different pattern you see on the right-hand side of affected speech or dysarthric speech. And in this specific study for FAST-AI, 400 patients were included. These are the breakdown of the patients, 45% female, the age of about 69, some hemorrhagic and some ischemic stroke, Bell's palsy in some of these patients, healthy controls in others, and so forth. And you can see that in this study, the neurologists, and this was a study that was conducted in Bulgaria. Currently, we're working on a US arm for the study and hopefully a Japan arm of the study. Neurologists are using the FAST-AI app on the real stroke patients. They correlate that with their clinical exam and impression. They correlate that with the brain imaging. Data is analyzed and the algorithm is optimized, the machine learning algorithm, and then continued testing and final validation happens. And there is adjudication by another neurologist who's not caring for the patient to look at agreeing or not agreeing with the AI output. And you can see here the sensitivity and specificity of each of the modules, speech, arms, and face. And for combined modules, looking at all three together, you can see that the sensitivity for yielding an alert of stroke is 99%, and specificity of 0.99 and specificity of 0.9. So these preliminary results confirm that smartphone-enabled machine learning algorithms can reliably identify acute stroke features with accuracy comparable to the neurologist's clinical impression. Now transitioning to Capture EMS. Again, this is available in Pomona, and this is with the goal of streamlining communications between EMS and hospital care teams. As you know, the pre-hospital communications is a complex one. There's a 911 call taker, a person who dispatches the patients. There's an EMS provider field encounter. There are base hospital communications, and then finally receiving hospital handoffs. These are some of the base hospitals we have in our Los Angeles County, including Pomona Valley Hospital. So what we need is an efficient and reliable way of communications. Currently, as I am in the field, we notice that some of these communications could be redundant or difficult because the paramedics not only have to care for the patient and chart in their EMR system or EPCR system, but then also have to make a physical contact to tell the base station. And the base station has to physically write down, and it's like playing telephone. And then the base station contacts the hospital. What if we can have something efficient, reliable? Everybody communicates all at once, and everybody's on the same page. And these are the goals of our app is to have clear communication, reliable communication between EMS provider and base hospital, EMS provider and receiving hospital care team, give feedback to EMS immediately with the final hospital diagnosis and patient outcome. And the other important part of this is the importance of data-driven quality improvement. So having provider impression, field hospital-based time metrics, critical patient treatment milestones, final hospital diagnosis of outcomes, and increasing the efficiency and accuracy of the data is desirable, and collecting them in a both time and cost-saving manner. This all came, to be honest, out of our need as physicians, seeing that, many times I get a page about a patient and half of the page is not correct. It's not even a woman, it's a man, and the last known well is incorrect and everything. So how do we expedite care for patients better as an interventionalist, as a stroke neurologist in the hospital, to be able to have a next of kin number, to be able to expedite their care once they arrive to us? It would be very helpful to have such an app. So in the app, you can create a unique EMS profile, a unique hospital profile, and all of the data is stored in a secure data platform. These are some screenshots of the app. It's fully customizable for LA County EMS. It is the first to offer base station communications. It focuses on EMS to receiving hospitals and data-driven applications. And there is a two-way texting and video communication option within the app as well to streamline the workflow. So this is what it looks like. To give you kind of some idea, you can register your account either as EMS or hospital. We have talked with the ITAC committee for LA County EMS, and we're green lighted to do a demonstration project, including a fire department, a base station, and a hospital. Currently in Pomona, we have launched the hospital-based part of this application, but we hope that we can engage also EMS partners and, of course, base station support, which we have in Pomona, to make this comprehensive. And so you can register and put your role, and you can register to what notifications you want to receive. This app is meant to chart for all EMS calls, which are ALS in nature, but we are starting with demonstration with the stroke module part. And so this is what the provider needs to fill out. They can very quickly tap, 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 enter the numbers, enter the age, enter some of the salient diagnoses and so forth. Choose the receiving hospital. That's how you at the hospital would receive it. They could take pictures of the patient. They can take pictures of the home meds, etc. And you can see stroke and STEMI, kind of similar layouts. And then you can actually have a video communication between the physician and the EMS as needed. And then once you are hitting en route, you can actually see the ambulance as it drives to your hospital by geospatial mapping. And on the clinician side, so let's say you're at the hospital now, you receive this case from EMS, then you can enter this same day feedback. This is what happened in the patient's care. And this is crucial and invaluable for teaching for EMS and giving feedback about what happened for that patient, because that's how we learn to do better. In the acute hospital setting, you can choose the diagnosis, whether it's ischemic or hemorrhagic. If you're giving IV thrombolytics, there's an IV thrombolytic calculator. You can enter all of your metrics, and as you easily timestamp these on an app, and multiple people can chart at the same time, as long as the case is closed. I mean, multiple people can chart within the same case, as long as it's closed and saved. And all of that data that we easily click, 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 we're all on our phones 100 times a day for different reasons, is actually extracted to a HIPAA compliant database where your coordinators on their side can funnel through the patients very quickly and look at their percentages of LVO and look at the diagnoses and actually extract that with one click into a CSV file. And so hopefully this would be one day easier to get with the guidelines, and we look forward to an integration one day directly into Get with the Guidelines to reduce your time. So these are some of the things I wanted to discuss with regards to the app. So looking at combining these two approaches, so what do we anticipate? We anticipate the fast AI approach to have video, sensor data, speech data to monitor. We'll have the fast AI core, which includes the face, arm, and speech. And this includes both post-stroke and acute stroke phase care with EMS integration. So we are integrating the fast AI with Capture EMS app. So within Capture, you can click on the Fast AI module and do these tests for the patients in the field. In terms of post-stroke, also you can target these for patients at home if they're having symptoms and need alerting. But one development of this, what we hope, we have the Capture and EMS as a standalone, we have Fast AI as a standalone, then there will be an app that combines both and also has a patient interface, and then something that includes everything. The real future of this is ambient detection. A stroke patient cannot pick up their phone while they're having a stroke to screen their face. However, on a Zoom, there could be a plugin. On Tesla, where you have a huge screen in front of you, other Apple and Google applications, insurance company applications. And if you think about it, even doing telemedicine for a patient and having this device kind of screen would be incredibly useful. So with that, thank you very much, and I'm happy to answer any questions at this time.
Thank you. We're so excited with all these technology. We have Rapid AI and we have now Capture EMS that we started go live on October 10th. And we started with our MICN. We didn't have any EMS involvement yet. We started with our MICN inputting the field information, and then we start from there. So far, it's exciting. The communication is much faster. We don't have to go several, like you say, playing telephone, one communicate to one another. So, any questions for Dr. Noor?
I just want to add that we're just so passionate about advancing pre-hospital to hospital care. There's so much good that we can still do, and the medics on their end have so much desire to get things right and to help patients. I think Sophia had a question about the IO-TPA. Thanks, Sophia, for the question. In fact, we have given IO-TPA twice so far in patients, and I'll say the first time, we didn't know it can be given IO, and at the time in the field, time is counting, and we couldn't get IV access at all. And then we just started looking on PubMed very quickly, and we saw precedence for IO administration of TPA in cardiac patient, and based on that, we were comfortable to try it. And to be honest, the first time around, we didn't have anything for kind of lidocaine or anything that we can inject for numbing, and gave the IO, and it was painful for the patient. And so for that time, it helped the patient. The TPA helped the patient. The patient's stroke symptoms improved dramatically. We're glad we gave it, but it was a big learning lesson for us that we should give the numbing also. So we started carrying that on the rig, and in fact, we gave a second patient IO, and this was a patient who was in a cardiac rehabilitation with witnessed onset right MCA syndrome. She, while walking with a physical therapist, dose is the same. While walking with a physical therapist, had symptoms. We were on scene within 30 minutes of last known well time. We could not get IV access, so we thought the most prudent thing to do is just give the IO access. And we were very happy the first time we gave IO. We said, oh, this is the first ever in the world. And we talked to Dr. Grada, and he said, oh, in fact, I did that also last week. And so we put our cases together and published it in a short communication, just to say this is available for patients who don't have acute IV access. Thanks for your question, Sophia. Also, we welcome anyone who would like to come and have a day on the mobile stroke unit to come and observe what a day is like to respond in the field. It is really a very passion project of ours, and it's really exciting to be there on the front lines.
We would love that. We're very excited to participate in the Capture study here, and then hopefully next year we'll have some really good data to share with the team as well. Thank
Thank
you.
you so much. And I'll put
Mhm.
in the chat, somebody asked about, is there a chat on this thing? Okay. Let me put
Yes.
our manager's email. Her name is Kayla, and you're welcome to contact her if you'd like to come for a ride along. And I hope I'm there that day and we can go over everything. But it's very exciting. And the thing that we are working on most now is to improve dispatcher impression. To be honest, the top look we looked at in LA County and LA County Fire, LA City Fire, which are the two largest 911 providers out of the 28 EMS providers. And most recently, we looked also at Long Beach Fire at the concordance rate between what the call taker, the dispatcher, thought was a 911 stroke dispatch and what the paramedic provider felt it was when they arrived on scene. The concordance rate between the paramedic thinking it was a stroke when they arrived on scene in LA City Fire is only 25%. In LA County Fire, the positive predictive value is only 34% of a stroke dispatch, resulting in the paramedic thinking it was stroke on scene. So that tells us a lot. We are getting canceled a lot on 911 calls for stroke. We are now needing to look at other we always have been attaching to other calls, like headache, that could be worst headache of life, or altered patient, or this or that. So we're working with an AI algorithm with a company called Cordy AI that helps enhance the dispatcher recognition of stroke. And we hope that that can allow us to better allocate shared regional resources like the mobile stroke unit. Well, thank you very much. I don't want to take up time of the next speaker, but I really appreciate you having us with you, and it's our pleasure.
Thank you so much for your time. Thank you. Excellent.